Okay, hello everyone. Welcome again to another video of our endocrinology playlist. Today we'll talk about adrenal gland disorders and the diagnosis and treatment of each adrenal gland disease. Let's start. So before we dive in the pathology and disorders of the adrenal gland, let's just give a brief talk about the anatomy and the physiology. The adrenal gland has two regions, the cortex and the medulla. The cortex itself is divided to three regions, the zona glomerulosa and fasciculata, and the third one is reticularis. The first one, glomerulosa, which is the most outer, this is producing aldosterone. Then in the middle, fasciculata produce cortisol. The last one, reticularis, produce androgens. Okay. Then comes the medulla, which is most medially or inside of the adrenal gland, and which is produced norepinephrine and epinephrine. It is important to know each part and which hormone is producing to know the disease and its own pathophysiology. Okay. So that's a diagram shows the cortex and the medulla. You can see the most inner is the medulla and the outer side is cortex, and each layer on which type of hormone is secreting. Move on to the disorders of the adrenal gland. As we used to classify the types of the diseases in the glands in general, we always have two types. Either it's the hormone is so much secreted, or there's a deficiency of the hormone. In case of excessive secretion of adrenal hormones, we have four diseases here, three in the cortex, one in the medulla. The first one, Cushing syndrome. This is because of high secretion of cortisol. Then comes primary aldosteronism, which is because of high aldosterone, or aldosterone is so much secreted in the blood. Other name for it is Conn's syndrome. Androgen producing adrenal tumor, that's zona fasciculata producing androgens. Then pheochromocytoma and paraganglioma. This is because of catecholamine secretion from the medulla of the adrenal gland. And the deficiencies, we have primary and secondary adrenal insufficiency. We will talk about each one. Starting with Cushing syndrome. Actually, the term syndrome here, it's an umbrella for everything under Cushing. Okay, so if you say Cushing syndrome, that you means Cushing syndrome because of adrenal gland, and Cushing disease, which is we discussed in the pituitary gland, is also under it. Okay. So it's a state of high cortisol in the bloodstream. The etiologies, the first thing, the most important etiology of the Cushing syndrome is exogenous ingestion of steroids. Okay, so take care of these patients who is an autoimmune disease, or for example, patients who have a cancer and they're taking steroids for as immunosuppressive. Those patients can develop Cushing syndrome. Okay, so just taper the drug and everything goes good. Then the second cause is the pituitary adenoma production of ACTH. That's called Cushing disease, but it's still under Cushing syndrome. Okay, and then the last one is cortisol secreting adrenal adenoma. This is adenoma in the adrenal gland secreting cortisol. The clinical presentation, as we mentioned in the pituitary adenoma slide, it is actually a stereotype. You will see it, you will never forget it, which is see in this patient. Patients who have Cushing syndrome, they will present with a high cortisol in the blood, and thinking about it as the physiology of the cortisol itself. When you have a high cortisol in the blood, it will suppress the immunity, so these patients, they will be susceptible for infections. Plus also cortisol would decrease inflammation, so they can get bruised so easily. So look for ecchymosis. Also, they are fat, so they will have red stria in their abdomen. The moon face, which is a circular face, you can see here in the picture, red cheeks and fat pads. Okay, try to know the whole picture. This symptom is unique actually for Cushing syndrome. Here, as we can see, also this is another picture. You can see here this is the moon face, and here the abdominal stria. Also, you can see there's a fat deposition in the whole abdomen, also on the breast. The buffalo hump is here, and probably this patient has ecchymosis in their legs or in their extremities. I don't see here, but I believe in his legs you will find ecchymosis. Okay. The diagnosis is actually there is a algorithm for diagnosing Cushing syndrome. How we diagnose Cushing, this is important actually in exams, like board exams. They always want you to know what is the most initial step, or what is the best diagnostic step. So always, whenever you suspect Cushing syndrome, check if the patient is taking medications or not. Okay, that's important, because it's maybe just about medication. You stop medication and everything goes good. If the patient is not taking corticosteroids, so what you gotta do, your first step will be a urine cortisol, urinary free cortisol values, and you want to check how much the cortisol in the urine. And there's also other tests. Sometimes they will ask you about it. It's called saliva cortisol. Okay, this is also could show up in exams in the place of the urinary free cortisol. So if this one is high, then you will do a dexamethasone suppression test, and that's you give a low dose of dexamethasone. And if the patient is normal, I mean they don't have Cushing syndrome, the cortisol will be suppressed. Okay, but in this case the cortisol is not suppressed, so you know this is Cushing syndrome. Then what you will do, you will check the ACTH. If the ACTH is low or undetectable, then you discover it. There's a negative feedback, so the pituitary gland is not secreting ACTH, so this is adrenal tumor. Okay, and if the ACTH is high or normal, so this is explained that there is a source secreting ACTH. Here it can be from the pituitary gland or the ectopic place, like lung cancer, for example. So what you're gonna do, you're gonna give the high dose dexamethasone test. If it's got suppressed, the ACTH is low, then this is Cushing disease because of pituitary gland. If it's not, then this is ectopic ACTH secreting hormone, and you need to do a chest X-ray or do a general investigation. Okay, so the key to take home here, you always start with saliva or cortisol test, then jump to dexamethasone, check ACTH, and if the ACTH is low, it's adrenal tumor. ACTH is high, then you do another dexamethasone. If the ACTH get low, the pituitary adenoma. If it's still high, that's ectopic ACTH, could be from lung cancer or any other cancer. Okay, and the management, usually it's a surgery. We remove the adrenal gland, and there is no actually medical treatment. You cannot control the symptoms. You just do a surgery and you remove the adrenal gland. Okay. The second adrenal tumor is in the cortex, which is we mentioned. The second one is a primary aldosteronism. This is increase of aldosterone hormone. This is primary cause of secondary hypertension. The primary hypertension is also called ascensional. The cause is unknown. Mostly it's familial. Okay, but the most common cause of secondary hypertension is Cone syndrome or primary aldosteronism, and there's another tumor is pheochromocytoma, which is we will talk about. The etiologies of Cone syndrome, let me write it here. this is Conn's syndrome. It's either one of the both, a hyperplasia or aldosterone producing adenoma. Which one is common? Hyperplasia. Okay. What is the clinical symptoms? So since we have a high aldosterone, so we are expecting a hypertension, headache because of hypertension, and blurry vision. Okay, most of the time they discover those cases after using more than one agent to try to decrease hypertension. So basically this patient will be on ACE inhibitor plus ARBs, angiotensin receptor blockers, also thiazide. They will be in a lot of drugs, and usually with patients with essential hypertension, they should be controlled on those drugs, but those patients are not. So in this case, we suspect a tumor secreting aldosterone. Okay. The diagnosis, how we diagnose aldosterone, how we diagnose primary aldosteronism or Conn's syndrome. We check the plasma renin and activity and the primary aldosterone activity. So how we do this? We basically we take a sample from the renal vein. We take a blood sample from the renal vein, and we will check aldosterone and renin levels. Okay, as the aldosterone increasing, because we have a tumor secreting aldosterone, normally the renin should decrease. Okay, because this is a negative feedback. So here we understand that that's a Conn's syndrome. If the renin is high and the aldosterone is also high, then this is a tumor secreting renin, not Conn's. Okay, which is rare, not common. So most of the time it will be renin low, aldosterone high. And if we saw this picture in the labs, what we're gonna do, our next step will be CT of the adrenal, because we want to know where is the place of this tumor. The treatment, if it's hyperplasia, not a tumor, then we give an aldosterone antagonist, and in this case will be spironolactone, the most common, or eplerenone. Which one is most used? Spironolactone, but take care that this drug is also androgen receptor antagonist, so you may see symptoms of gynecomastia or loss of libido, etc. You will see them more in males than female. Okay. And if it's a tumor, then you do adrenalectomy. You remove the adrenal gland. The third one, which is a tumor in the medulla. Okay, this is secreting norepinephrine and epinephrine. If it's in the adrenal gland, we call it pheochromocytoma. If it's in the spinal cord and sympathetic pathway in the ganglia, we call it paraganglioma. Okay. The etiology is the sporadic is around I believe 70%, and the genetics is around 30%. What is important, they always ask the genetic part. Okay, so they may ask you about VHL, von Hippolendo, what is the tumor seen in von Hippolendo, so it will be part of it, pheochromocytoma, also hemangioblastoma, and renal cell carcinoma. Okay. Men to A and men to B is also important, which is the 2 P's, 1M, and the 1P, 2M's. I think there's a picture showing the mnemonic for it. The symptoms will be the same as the Conn's syndrome, which is aldosterone increasing, because here we have also norepinephrine, increased attention. The only difference that I would like to mention that this is mostly seen in young people. Okay, so take care. If you see a 20 or 30 years old have headache, sweating, tachycardia, and hypertension, that's not acceptable. Think about pheochromocytoma. The diagnosis is super easy. You just you detect the metnephrine and in the plasma, and also in the urine. In the urine is best, is more specific and sensitive. Those are the the chemical degradation, which is the products of the catecholamines, okay, after they got degraded by the liver. After you diagnose the pheochromocytoma by high metanephrine in the urine, the next step will be doing CT to detect the place of the tumor. Okay, the treatment, you're gonna do surgery. There is no any other option except surgery. But before doing surgery, that's important. They always ask this in boards. You need to give alpha blocker, okay, alpha 1, 2, which is unselective alpha blocker. Then you give beta blockers. Why? Because if you start with beta blockers, you will give the epinephrine the opportunity to bind to all the alpha receptors in the body, and as we know, alpha receptors lead to vasoconstriction, so you worsen the situation here. Vasoconstriction will happen in the whole body, and the tension will increase, sometimes reaches 250, 300, and the patient will die. Okay, so alpha, then beta, very important. We use phenoxybenzamine, that's a alpha 1, alpha 2, and non-selective blocker. Then we do beta blocker. So never forget, important, A comes before B, alpha then beta. That is a mnemonic for MEN syndrome. You can look for it. It's important. You should know it. Also high yield. And keep in your mind that MEN2 and MEN2A, MEN2B are associated with Rett gene. Okay, they always ask this. The last tumor that's not common, that's the tumor of the zona reticularis secreting androgens. You will see a patient who have a menstrual irregularities if she's a female, virilization like hirsutism. In male, one won't show a lot of symptoms, voice deepening and increased muscle mass, mostly in female. Okay, how you diagnose it? You will have a high dehydroandrogen sulfate that is secreted from the adrenal gland. If you detect this hormone high, then do CT image to confirm the diagnosis. And the treatment, you resect the tumor as the other tumors. The last thing, which is a high yield topic, it's adrenal hormone deficiency. Okay, this is a high yield. They ask this, especially in step 1 USMLE. This is a condition which is the total opposite of the adrenal excessive hormones. Here we have deficiency of most of the hormones, sometimes only one, or sometimes most of them. The most common are deficiency of cortisol. Okay, and it could be primary or secondary. Primary means deficiency or means a problem in the adrenal gland itself. Secondary means a problem in the pituitary gland is not secreting ACTH. Okay, so what is the etiologies? First thing is Addison disease. That's an autoimmune distraction of all the layers of the cortex, leading to progressive mineralocorticosteroid, aldosterone deficiency, and glucocorticoid, cortisol deficiency, and adrenal androgen deficiency. Then the second thing is TB. Okay, so this is seen more in the developed countries, the Addison disease, and this is seen in undeveloped countries. Okay, so if they mention patient came from Asia or from Africa, think about TB. Okay, and TB can lead to adrenal deficiency. Infiltrative, seen with sarcoidosis and lymphoma, and ACTH deficiency, that's of course the secondary. The symptoms, think about each hormone and its own physiology, and the deficiency of this hormone will lead to the opposite symptoms. So for example, deficiency of aldosterone will lead to salt craving, so the patient wants to eat more salt to increase the pressure and dizziness. Anorexia, nausea, vomiting, and abdominal pain, this is because of cortisol deficiency. Loss of libido, that's because of androgen deficiency. Okay, and the important thing, and that's a hint in the exam, if you see hyperpigmentation, that means that's primary adrenal insufficiency, because the gland, the adrenal gland is not secreting the hormones, so the pituitary gland will sense this and will start to produce a lot of ACTH. And we know that ACTH comes from a chemical component called POMC. This POMC will give you ACTH and also melatonin stimulating hormone. So whenever you increase this thing and you want more ACTH, you should increase POMC also. So the MSH will increase and you will have a lot of melanin, leads to hyperpigmentation. Okay, so hyperpigmentation, it's a hint for primary adrenal insufficiency. There's a picture of patient with a primary adrenal insufficiency having hyperpigmentation. You can see here around the nose and also in the hands here, there, also there. But what I think it's more important, especially in black patients, you cannot detect in the face hyperpigmentation. It will be inside the mouth. So look at the pigmentation in the tongue, and look here behind the tooth. Here also pigmentation in the palate and also in the tongue here. So that's important, okay? And collaborate with the symptoms of adrenal insufficiency. Labs, as we said, you will see a deficiency in all hormones. Not always the case, but mostly you will see deficiency of cortisol and aldosterone. So deficiency in aldosterone, you will detect it by how? You will see a low sodium and high potassium, because aldosterone reabsorb sodium and excrete potassium. So if you don't have aldosterone, you will have low sodium and high potassium. If the ACTH is high, then that's indicator for primary adrenal insufficiency, and we said hyperpigmentation is the symptom. How you treat it? You give the replacement for cortisol, which is hydrocortisone. It's better than dexamethasone because this is equal to the normal body cortisol. Okay, and you will give fludrocortisone, that is the analog for aldosterone. Okay, aldosterone. Yep. So never forget this. And this is the end of this talk. See you in the next video.